Hello, everyone. Good afternoon, good evening, good morning, depending on from wherever you're joining in. As you're aware, this is World Antimicrobial Awareness Week, and we had our first webinar yesterday where we talked about the AMR education, FIP AMR education report. Today, we are here for another exciting webinar. I promise you, this is going to be a very insightful and exciting webinar with loads of new information, and that is on new roles of pharmacists in antimicrobial resistance with the focus on fungal disease management. I myself, Mrs. Manjari Heret, the FIP Vice President and the co-chair of AMR Commission of FIP. I extend very warm greetings on behalf of FIP to everyone who had joined here today. And also, I extend warm greetings to those who are going to watch this webinar later on the YouTube. Thank you again for joining from all across the globe. Next slide. Before I go to the webinar, let me have some announcements. Many of you are already familiar with these procedures, but it's my pleasure to repeat it again. So this webinar is recorded and it will be live streamed via YouTube. You can also watch it later on the YouTube. Also, the recordings will be made available on the website of FIP, events.fip.org. So if you miss it right now, or if your colleagues want to watch it, please do visit this website of FIP. We encourage you, we appeal you, we invite you to ask your questions in Q&A box, which will be provided, and you're free to ask your questions, and our speakers will be very happy to answer it right there by the text message or at the end of the session when we can have live Q&A depending on the time. You are welcome to provide the feedback to FIP via webinars at fip.org. This is specifically so that we can improve further. And if you're not yet a member of FIP, I'm sure many of you are already members of FIP, but if you're not yet a member of FIP, please, I request you to visit fip.org, the membership site, and become a member of this global family. FIP is the federation which represents 4 million pharmacists, and it will be great to be a member of this global family of the pharmacist. Coming to today's exciting webinar, the learning objectives that we have today define the drug-resistant fungal infection and its posed public health risk. Describe the potential role of pharmacists in appropriate antifungal use and stewardship. Outline the educational and policy needs for the management of the fungal infections. So the agenda for today, the opening remarks and the introduction by the chair, and that's what I'm at. I will also walk you through the FIP showcases of the impact database. And then we start with our topics for today, the antifungal resistant fungal infections, for which we have a speaker from World Health Organization, Dr. Valeria Gigante. Then we have the next speaker, Dr. Dallas Smith, who will be speaking about the role of pharmacists and educational needs in the prevention of antifungal resistant dermatophytes. And then we get the hospital pharmacy perspective by Daria Kurupoe and Anna Kanina, and they will be talking about the development of antiviral and antifungal stewardship. Then comes the time for the Q&A session, and then the closing remarks by myself. So this is the galaxy of the speakers we have, Dr. Dallas Smith, Dr. Valeria, and Dr. Anna, and Dr. Daria. Thank you very much for joining. I profusely thank our speakers for joining the webinar, and they're going to share their knowledge and insights about the fungal resistant infections and the stewardship. So I will now walk you through what is AMR Commission. So as many of you know that in September 2020, yes, during the COVID pandemic year, FIP launched 21 FIP development goals to guide the transformation of the pharmacy profession locally, nationally, and globally. One of the development goals, that is DG17, focuses on antimicrobial stewardship. And this goal has 3 elements, that is the workforce, practice, and the science element. And the workforce element aims to develop the strategies and systems in place to develop the strategy and systems which should be in place to develop a pharmaceutical workforce who is prepared to deliver the quality services for antimicrobial stewardship, because there cannot be good practice, there cannot be right practice without the right workforce. Then when we are talking about the practice element, the DG focuses on the infrastructure and the framework in place to deliver the services for antimicrobial stewardship. And the science element focuses to promote the research and the development of new antimicrobials, new antibacterial combinations, and the new techniques, and evaluate the impact of antibiotic stewardship programs. FIP has antimicrobial resistance as it's one of the top priorities since very long. In 2008, FIP released a statement of policy control of AMR. In 2015, the report came up that is Fighting AMR, the Contribution of Pharmacists. In 2016, at the 68th World Health Assembly, in every World Health Assembly, FIP represents the pharmacist. So FIP contributed to the Global Action Plan on AMR. And in 2017, the Statement of Policy Control of AMR was released. In September 2020, as I said before, there was a launch of FIP DGs. And also, FIP took a very important step of formation of FIP AMR Commission. In 2021 and 2022, we had series of digital events focused on AMR action through AMS. In 2021, also, FIP contributed to the 74th World Health Assembly. And in 2022, we had series of webinars on antimicrobial stewardship. In 2023, the FIP AMR Commission was reconstituted, mainly focusing on the FIP DG17, and there was creation of the repository, which focuses on the DG17. Now, I'm very, very proud and pleased to show you this slide, which introduces you to the FIP AMR Commission members. So this is the reconstituted AMR Commission from FIP. And I, along with Professor Katia Canares from Portugal, co-chair this AMR Commission. And then we have 15 experts, pharmacy experts who have expertise in AMR from diverse field and from all across the globe. We have 15 experts in our AMR Commission who contribute passionately to the progress, to the work of the Commission. And we are well supported by FIP staff, Zuzana and Isu. And our inspiration and the pillar of strength is always none other than the FIP CEO, Dr. Catherine Dutton. So now talking about the FIP Statement of Policy on Mitigating Antimicrobial Resistance through AMS, through Antimicrobial Stewardship. I told you that we have a report from 2017 on the control of antimicrobial resistance. Now, this report was updated. This report is revised and updated with mainly two objectives. That is to include the more emphasis on the antimicrobial stewardship and the One Health approach. The One Health approach where the human, animals, and environment interface is considered. And then also another objective of updating this report was to provide the detailed recommendations for pharmacists, governments, and policymakers who, in collaboration with the member organizations of FIP, can work to mitigate the AMR through the antimicrobial stewardship. I'm very pleased to tell you that this report, that is FIP Statement of Policy on Mitigating AMR through AMS, will be launched tomorrow in WHPS session. Thank you. Next slide, please. Before we go to the webinar topic of today, that is the fungal infections, let me quickly walk you through the FIP showcase of the impact database. Now, this impact database showcases the pharmacy's evidence-based achievements in practice, workforce, and the policy matters. So if you see, selecting any of these buttons will display a visual representation corresponding to each impact. So this is part of the Global Pharmaceutical Observatory, which is a huge database collection. And so there are the buttons like impact by publication team, impact by FIP development goal. Just have a look here. So we have several publications which are focusing on each of the DGs. So the FIP's outputs, publications, as well as the related publications. Next slide, please. So the FIP Impact Database. This project is a strategic initiative by FIP with three main objectives: creating a comprehensive database of FIP outputs, as well as the related publications, analyzing the data-driven evidence of practice, workforce, policy transformation, and impact of FIP work, and preparing a high-level summary of evidence and impact demonstrating pharmacy's contribution to the healthcare. So with the aim to help FIP and its member identify and track the trends, impact evidence, service details, and advancements in pharmacy, offering annual updates to highlight the latest accomplishments and developments. So with this aim, this FIP impact database project has been developed. And the process is, this entails extracting FIP outputs and the related publications on specific themes, like for example, achievements, challenges, workforce trends, lessons learned, and recommendations. So this is basically to help the MOs as well as the members. And when we are talking about AMS, antimicrobial stewardship, what did we find so far? So there are some of the findings. Pharmacists' role and contribution in AMR. Pharmacist-led immunization can reduce the antibiotic resistance by increasing vaccination rates and reducing the need for antibiotics. Pharmacists contribute actively to educate the public on infection, prevention, and control strategies. Pharmacists support AMS by integrating guidelines into infection control, optimizing therapy, and advocating for awareness and policies regarding AMR. And pharmacists also contribute to safeguarding supply chain process to combat the counterfeit medicines. I think these are very, very encouraging findings about the pharmacist's role and contribution in AMR. For the future, the recommendations are economic incentives combined with increasing initiatives in research and development could be a solution to AMR, specifically in the development of new antimicrobials. Adopting a One Health approach, which reduces AMR risk and effects originating from the human-animal environment interface. Developing guidelines and policies can provide tools for physicians and the dispensers to educate the patients on antimicrobial use and improve the patient's medication adherence. As vaccines help reduce the need for antibiotics, there is need to expand pharmacist role in vaccination. So these are the recommendations which come from this. Yes. So yes, next slide, please. Now it's my pleasure to go to the first presentation of today's webinar, and that is antifungal resistant fungal infections, the World Health Organization WHO perspective. And to deliver this talk, we have with us Dr. Valeria Gigante from who is a WHO team lead at AMR Division, Switzerland. And this is really great to have Dr. Valeria here, and I'm sure we will have wealth of knowledge and new information from her presentation. So I'm very excited to welcome Dr. Valeria. Dr. Valeria?
Thank you so much.
Yes, go ahead.
Thank you for the opportunity to be here today. I work at WHO, where I'm responsible for research and priority settings. I'm a clinical pharmacologist, but I'm also a pharmacist. So it is really meaningful to be here today to discuss our work and our potential way forwards to fight fungal-resistant drug-resistant fungal infection. This is my disclaimer statement, and I would ask for the next slide. Thank you so much. So overall, there are 200 fungi known to cause disease in humans. And among fungal infection, we can have common infection affecting the skin or the mucosal tissue, like the athlete's foot, vaginal yeast infection, and they are generally susceptible to therapies. But there are also more dangerous drug-resistant fungi, causing invasive fungal infection of the bloodstream. These infections are rising, particularly among the immunocompromised population that is growing globally, and show limited or no responses to available antifungal drugs. They are associated to prolonged illness, treatment failure, and high morbidity and mortality rates. But despite this concern, fungal infection receive very little attention and resources. So it's impossible today to estimate the exact burden of this infection. Next slide. Last year, the ID team in the Turin City's Hospital in northern Italy started suspecting of a fungal infection where the IUC patients kept developing fever, no matter what therapies they administered. They understood it was not a virus, not a bacterium, and they were worried that this infection could spread through the hospital while tests were carried out. They eventually identified the Candida auris, which is often drug resistant and has spread to the world since its first identification in 2009 in Asia. And it was the first time they were encountering it in children. Candida auris is dangerous for patients in poor health. 1 in 3 of those who contract it can pass it away. So rigid IPC measures are needed to contain the infection. In carrying and transferring for patients with Candida auris, for instance, and also environmental cleaning is very important. Last year, WHO classified Candida auris as a critical threat. Next case study, please. That is about Aspergillus fumigatus. Is one of the most dangerous fungi and is classified by WHO as a critical threat. It fights with the host over iron and finds a clever way to take iron away from its host. We constantly inhale the Aspergillus spores indoors or outdoors without becoming ill. But for people with a weakened immune system, Aspergillus is fatal in the 30 to 60% of cases, even with tailored treatments. And these data are probably an underestimation of the real threat because aspergillosis is not a reportable disease today. Next slide. So when treating patients with HIV with severe and persistent headaches, healthcare providers rarely consider it could be a meningitis, despite its prevalence in the HIV population. Cryptococcal meningitis is a serious illness and is caused by Cryptococcus neoformans. It's responsible for approximately 15% of HIV-related deaths worldwide, but in low and middle-income countries, it causes up to 50% of HIV-related deaths. The population at risk is people with a weakened immune system. For instance, patients with HIV or organ cell transplant, cancer patients, patients with diabetes, patients taking corticosteroids or other medication that weaken the immune system. Next slide. Histoplasma and Coccidioides. Histo and Cocci are environmental fungi with geographical niche in the US and globally. They cause infections that are often confused with bacterial or viral pneumonia. And patients with Histo or Cocci are often prescribed antibiotics which are ineffective against fungal infection and worsen the overall clinical manifestation. Patients are rarely tested for these fungi, even in those areas of the US where they are most common. And the reason for this is the lack of awareness. Next slide. So to raise awareness of this serious life-threatening infection, in 2022, WHO developed the first fungal priority pathogen list. The list prioritizes fungal pathogens considering their unmet R&D needs and their public health importance. And we have seen already case studies on Candida, Crypto, Aspergillus among the critical threat, and also Histo and Cocci from the high and medium group. Next slide. So within the FPPL development, we identified the 3 priority areas for action, and every one of us can play a critical role supporting this area of action. They are surveillance. Robust surveillance is crucial for monitoring the development of resistance, ensuring timely action under national strategies and plans. R&D, so the researcher, to push progress in research and innovation. And public health intervention to implement effective IPC measures tailored on the local context. And these 3 areas are somehow very strictly interconnected and strengthen one on each other. And next slide. So the purpose of developing this list was to direct R&D efforts towards the pathogen that pose the largest public health threat, to define R&D priorities, to align investment and funds, also to enable international coordination in R&D, and facilitate the regular review of the antifungal pipeline. Through the development of the list, we understood that 2 things. First, that there is a huge data gap on the global burden of invasive fungal disease and fungal resistance, especially in low and middle-income countries. And second, that a tailored approach is needed to match the size and the complexity of the problem. Next slide. The impact of drug-resistant fungal infection emerged dramatically during COVID. In India, the overprescription of steroids to treat COVID weakened the immune systems of many, leading to numerous cases of black fungus, also known as mucormycosis. The prevalence of mucormycosis in India were 80 times higher than in other countries. And drugs to treat mucormycosis were in short supply. So WHO had to step in, calling for increased supplies and lowered prices. Mucormycosis are disfiguring and lethal infection. They start in the nose and rapidly spread to the eyes and brain, resulting in a high fatality rate. The fatality rate was approximately 70% among patients with disseminated mucormycosis, and again, this could be underestimation. And this shows the consequence of invasive resistant fungal infection that, paired with the lack of appropriate therapeutics, appropriate diagnostics, can only worsen a public health emergency. And in this presentation, I showed not to, I decided not to show picture of this infection, and most of the pictures also that we can find online are censored by the search engines. Next slide. So as we have seen in all our case studies, invasive fungal infection have their higher implication on the immunocompromised, vulnerable, and fragile population that keeps growing globally. And this is due to probably the advancement in other therapeutics area that expand the population at risk. Patients at risk are also patients with chronic lung disease, patients with TB, HIV, cancer, diabetes, but also ICU patients undergoing invasive medicinal procedure, patients receiving broad-spectrum antibiotics, and also patients with cell and organ transplants. And it's important to notice that any one of us can become an immunocompromised or a vulnerable patient at any point in time. And population displacement also can play a role. And the climate change with flooding and devastation creates a suitable environment for fungal infection. We think about the buildings that are old and down. And there are also global challenges with access to medicine and diagnostics and shortages to medicine. Next slide. But let's see in particular the challenges with diagnostics and treatment. So the diagnosis of some invasive fungal infection is difficult, exactly because of their invasive nature, and require also multiple tests and approach for identification. There is also a lack of standardization in test methodology among laboratories. Tests could present sometimes low sensitivities, long turnaround time, difficulties with interpretation of results, other than high cost for a broad uptake also in low and middle-income countries. If you look at the available therapy, we have a limited number of antifungal treatments for systemic use. There are only 4 classes of antifungal drugs authorized today. And they have common drugs. They are characterized by, so the treatment are characterized by long treatment course and high incidence of adverse events that leads to poor compliance in patients. If we look at the pipeline, so at the potential drug candidates that might arrive on the market in the future, we can see a really dry pipeline with less than 10 drugs in development today. And this scarcity is due to 2 elements, the scientific and the financial challenges. So regarding the scientific challenge fungi are eukaryotic like humans. So we share many biological pathways. So it's difficult to target fungi without harming human cells. Regarding the financial challenge, the economics of antifungal drug development pose a considerable hurdle, with cost often outweighing the return of investment. Next slide, please. So the incidence and geographic range of invasive fungal disease is considerable and may be expanding, but we have a positive quality data on fungal disease distribution and antifungal resistance pattern. And one reason is the lack of evidence. And this is due again to the lack of awareness of fungal infection. Someone said that the index of suspicion for fungal infection is low to non-existent when providing diagnosis and treatments. But opportunities like the one we have today to engage are crucial to raise awareness, curiosity, and maybe to push up the index of suspicion towards fungal infection when they are present. Next slide. So in conclusion, the fight against AMR requires the prioritization of resources, investment, commitment to enable the implementation of effective and tailored strategies, but also multi-phase intervention are needed on IPC, on surveillance, expanded the laboratory capacity for quicker, affordable, and quality tests, for effective and non-toxic treatment, with stewardship and training for healthcare providers. So the fight against AMR requires everyone's commitment, and the pharmacists have a key role in taking appropriate decisions and implementing effective measures to prevent drug-resistant infection from becoming the next global health and public health emergency. Thank you.
Thank you so much. Thank you so much, Dr. Valeria. That was a wonderful presentation. And thank you for introducing us to the serious critical fungal infections and also talking about all the factors which are contributing to this resistant infections. And what you said is right. AMR is everyone's commitment, and pharmacists have a key role to play. And thank you very much. We'll have you for the Q&A session. So thanks. So now we go to the role of pharmacist. As Dr. Valeria rightly said, that pharmacists have a key role to play and here we have Dr. Dallas Smith, who is an epidemiologist in Mycotic Diseases Branch, Center for Disease Control and Prevention, CDC, United States of America. He's going to discuss the role of pharmacists and educational needs in the prevention of antifungal resistant dermatophytes. So I'm sure this is another very insightful and exciting talk. Dr. Dallas Smith, welcome.
Thank you so much. Next slide, please. And so I get to talk to you about an outpatient stewardship concern that I think is really important for pharmacists to really get involved with. And what we're going to talk about today are dermatophytes, or more commonly known as ringworm. And I just wanted to mention that I'm with the Mycotic Diseases Branch. I'm an epidemiologist, but a pharmacist by background. And the Mycotic Diseases Branch is one of the only public health organizations or organizations really dedicated to public health of fungal diseases. And so I'm really excited to be here today as a pharmacist and an epidemiologist to talk to you about antifungal resistant dermatophytes and the continued emergence globally. Next slide, please. And so I just want to take a step back and just talk a little bit about ringworm in general. And so ringworm, which is also known as tinea or dermatophytosis, is a fungal infection that affects different parts of the body, most commonly the skin, hair, or nails. It's very common. Some estimates state that maybe almost 25% of people have had ringworm sometime in their life. I am also one of those individuals who've had ringworm when I was younger. It's caused by a variety of molds. And so some of the most common molds are mycosporum or trichophyton. And what ringworm is really known for is it spreads easily among people and by animals, and also by fomites. So just little fungal spores or fomites that hang around on clothing, for example, or other articles that are shared between individuals. And some of the symptoms that we see with ringworm includes itching, scaling, and the most common feature is the ring-shaped lesion. Next slide, please. And so the way ringworm infections are named, it's actually named by the side of the body. And so I just put a few examples on the screen here. But for example, a lot of the times we think of ringworm, we think of jock itch or a groin infection, and it's named Tinea crucis, while Tinea capitis is a scalp ringworm, and so on and so on. And so we actually have three different things. We have ringworm, which is the overall name. We have the tinea location, for example, Tinea capitis. Then we also have the fungi that's causing ringworm, which could be a trichophyton species or another species of mold. Next slide, please. And what we normally do is the normally way we treat ringworm infections are because they're often mild, we can treat them with over-the-counter antifungals, and normally we use topical antifungals, which really don't require prescription in most parts of the world. And I think a lot of us on this call have probably gotten questions from patients about how can I treat this ringworm? And instead of going to a physician or another prescriber, that normally the first encounter is with a pharmacist. For more severe infections or infections that aren't able to be treated with topical antifungals, the next line of defense is the next line of therapy are normally oral. Can you go back? Yes. Are normally oral antifungals, including terbinafine, griselfulvin, or even some of our azoles like itraconazole. And then what we normally see is that with severe infections, they're usually in immunocompromised individuals, whether that's HIV, whether they're taking immunomodulators, or some other condition that would cause their immune system to be depressed. Next slide, please. And ringworm is not just a cosmetic concern because we think of it as a skin infection. Normally, it doesn't lead to mortality, but there are other burdens that people deal with when they have ringworm. And one of the biggest things is it causes stigma and a decreased quality of life. And it's really important to treat this so that we can continue to improve patients' lives by addressing some of these non-mortality burden measures. It can also result in missed work in school. There's also a potential for bacterial superinfections, particularly in patients with diabetes. It's a substantial healthcare burden because it is so common. And then also we can have outbreaks due to ringworm, whether that's from animals, whether that's in a veterinarian office, in an animal shelter, or in human settings too, especially in congregate settings. Next slide, please. And what we normally see is that ringworm is diagnosed usually just by visual inspection alone. However, when visual inspection is done is often inaccurate because ringworm can look like other skin diseases. And testing can help improve diagnostic stewardship. And so like I mentioned, fungal and non-fungal rashes can look very, very similar. Studies have shown globally that there's frequent misdiagnosis, which leads to inappropriate treatment. Some diagnostic testing that we do for ringworm includes potassium hydroxide preparations. We can do a culture, and then also we can use some molecular testing like PCR to actually get a diagnosis, which is really important in order to properly care for our patient and be good stewards of antifungals. Next slide, please. And so the reason I wanted to bring this up is that globally, we're seeing this emergence of antifungal resistant ringworm. And it's a huge problem right now in South Asia caused by a novel pathogen called Trichophyton endotiniae. And although South Asia bears a large burden of the disease currently, I'll show some data in a little bit that it is spreading across the globe. And so this antifungal resistant ringworm is more severe than normal ringworm. It's more widespread throughout the body. It usually affects the trunk, arms, legs, groin, and or face. And what's really concerning is that topical antifungals don't work, and it's normally and frequently resistant to terbinafine, which is one of our first-line oral therapies for ringworm. And then what's really, really concerning is that we have seen some isolates or some infections that are resistant to itraconazole, which is a second-line oral treatment. And because it is ringworm, it can spread easily from person to person or from animals to people or vice versa. Next slide, please. And when we started thinking about what is causing this emergence of this new ringworm species, we think it is associated with the misuse and overuse of creams containing highly potent steroids or corticosteroids, antifungals, and antibacterials. And these are readily available throughout the world with a prescription and most of the time without a prescription. And so a lot of the times they can walk into a pharmacy, maybe consult a pharmacist, maybe not, and get these creams that have a high potent steroid and antifungal and antibacterial. Next slide, please. And so by early 2023, cases of severe ringworm caused by this new species, this Trichophyton endotiniae, had been detected throughout Asia, Europe, and in Canada. And recently we found an infection in Mexico and parts of the Middle East. And so we continue to see the spread. And if I had to guess, this infection is more widespread. It's just we don't have the capacity to diagnose this in a lot of settings. And I'll talk about that in a little bit. Next slide, please. And I just want to talk a little bit about the US. And so early in 2023, we published some reports of the first cases of this new species, Trichophyton initiniae, in New York City. It was 2 different cases. These patients had long diagnostic delays and received multiple rounds of antifungal treatment. Interestingly, both patients were immunocompetent. And we see this commonly with Trichophyton initiniae. Even though the ringworm is widespread, these patients have no underlying immunocompromising conditions normally. One of these patients in the US had recent travel to Bangladesh and exposure there, and the other patient lacked known exposure. And so we think there is local spread going on in the United States and also other countries where this new species is introduced to. And as you can see on the right-hand side, these are some pictures from patients. This, as you can see, the ringworm is widespread. It's on the stomach, it's on the legs, and it's very severe. Next slide, please. And although we are one of our main concerns is with Trichophyton initiniae, which is that new species that I mentioned, we have seen ringworm caused by other resistant dermatophyte species in the United States and globally. And the other one that we've seen resistant in is called Trichophyton rubrum. And this also causes difficult to treat tinea corporis and some other locations on the body. And what's really interesting is these patients have required treatment with posaconazole, which is an azole generally reserved for life-threatening mold infections. But because of resistance, posaconazole is really the only drug that's working for these patients. And so we want to be good stewards so we don't have to use this drug that has a lot of side effects, drug-drug interactions for a superficial disease like ringworm. Next slide, please. And so one of our partners in the United States was able to do some retrospective review of isolates that he had of ringworm species. And we found that this ringworm, either Trichophyton initiniae or Trichophyton rubrum, has been detected in 11 US states. And when we looked at antifungal resistant or antifungal susceptibility testing, we found that almost 20% were resistant to terbinafine, which I mentioned before is usually our first-line therapy orally to treat some of these ringworm infections. So it's really concerning in the US. And there's a lot of data in India, in Bangladesh, and some other countries in the world where it's just continued to emerge and increase, and it's really concerning. Next slide, please. And so one of the things I wanted to mention was that it's very difficult to diagnose these resistant ringworm strains, and culture may not tell the entire story. And so potassium hydroxide preparations and microscopy cannot distinguish Trichophyton initiniae, which I mentioned is frequently resistant to some antifungals, from other common dermatophyte species. Usually we have to use advanced molecular techniques like PCR to have a definitive diagnosis. And globally, in the United States and Europe, this laboratory capacity is very, very limited. And so, unfortunately, we're kind of flying blind because we aren't able to properly diagnose these resistant ringworm infections. Next slide, please. However, pharmacists can help stop the spread, and is probably going to be one of the most key players in controlling the emergence of this resistant ringworm infections. The pharmacists are usually the most accessible healthcare professionals in many countries. And one of the biggest roles pharmacists can play is encourage the judicious use of topical antifungals, and more importantly, topical antifungal and corticosteroid creams by both prescribers and patients. Next slide, please. And so I want to talk about four main next steps that pharmacists can help stop the spread. So the first one, and I'll go through these throughout the slides. So next slide, please. And so the first one is that pharmacists can be effective stewards of antifungals, particularly in the outpatient setting and with over-the-counter medications. And this is very different than what we normally think of antifungal stewardship, which my colleagues from Europe will talk about in a little bit. But outpatient antifungal stewardship is going to be really important going forward as we think about how we can control the emergence of this skin infection, which is going to be diagnosed and treated in outpatient settings. And so, as I mentioned, in many countries, these high potency corticosteroid creams can be purchased over the counter. And many times they're combined with an antifungal. And this is most likely driving resistant and causes severe side effects. And so pharmacists can intervene and can educate patients about the risk of use of these medications. And they can also encourage patients to seek diagnosis from a provider, because we want to make sure that we are actually treating ringworm and not a non-fungal skin infection. And we want to make sure that we're getting the proper medication, because many times the corticosteroid component is not needed. These infections can be treated with just a topical antifungal. Next slide, please. The second thing we can do is pharmacists, especially those on this call, can raise awareness among other healthcare providers on how to recognize and treat antifungal resistant ringworm. Because it is an increasing commonly problem, specialized testing is needed for diagnosis, which pharmacists normally don't have access to. However, if pharmacists can encourage clinicians to do the specialized testing or to get a definitive diagnosis, this will go a long ways in caring for patients. Pharmacists are usually able to gather patient-specific social history, including travel history, previous use of antifungals or topical antifungals, topical corticosteroids, in ambulatory and community settings where sometimes prescribers or clinicians or physicians are not able to get. So when we get this information, we could contact primary care providers or their main clinician to update them on these details that we discovered. Next slide, please. Thirdly, pharmacists can help manage drug-drug interactions and side effects. Because these ringworm infections are often resistant to our first-line therapies, we're going to have to use triazoles in some cases. For example, itraconazole. Itraconazole is not the easiest drug to work with. It has drug-drug interactions, it has absorption and pharmacokinetic issues, and it has side effects as well. And so pharmacists, being the drug experts, can intervene and really help manage this baggage that itraconazole and other triazoles have. And so pharmacists can help guide patients and clinicians to ensure the appropriate adjustments are made to other medications if there are drug-drug interactions. They can also play a critical role in therapeutic drug monitoring of itraconazole or other triazoles, because there are absorption issues, there are other issues that may not correlate from the dose to how much drug is actually in the blood. There may be a role where we can help measure the drug in the body and adjust the dose if needed. But probably most importantly, pharmacists can help educate patients and other healthcare professionals about potential side effects of itraconazole and of these other triazoles needed to treat resistant ringworm. And these side effects are almost endless, and they can be pretty severe. It can include hepatotoxicity, cardiac arrhythmias, visual disturbances, hearing loss, phototoxicity, and pseudohypoaldosteronism. And so we need to be aware of these side effects and need to be able to help manage them if these medications are going to be used. Next slide, please. And then finally, pharmacists can help educate public health professionals, the general public, and also other pharmacy colleagues. I see there's almost 300 people on this call, which is really great. And we need to help spread this information to other pharmacists and also the public. And we're also in a unique position to collect surveillance data from the public in order to better understand the burden of disease, risk factors, and transmission. We can host fairs at pharmacy schools and in the community to help talk about this issue and make sure that people are getting the appropriate treatment. And then also we can design continuing education for pharmacists around this topic to make sure that we're educating our fellow colleagues. Next slide, please. And so take-home points. So antifungal resistant ringworm is an emerging public health issue, and it requires a multidisciplinary approach. Community pharmacists, because they're often the most accessible healthcare professional, are valuable global healthcare professionals who can help stop the spread of antifungal resistant ringworm. And we can do this by the 4 things I just mentioned, including being effective stewards of antifungals, including over-the-counter medications. 2, encouraging multidisciplinary collaborative care. 3, spearheading pharmacological interventions like managing drug-drug interactions and educating about side effects. And then 4, and probably most importantly, informing the public, other healthcare professionals, and public health on emerging epidemiological trends for drug-resistant ringworm. Next slide, please. And I just want to thank you all for listening. I'm happy to take any questions at the end of this session, and I'll turn it back over to our moderator.
Thank you. Thank you so much. This was an excellent presentation, and I'm very glad we could hear it from a pharmacist who is an epidemiologist, or an epidemiologist who is originally a pharmacist. You have pinpointed all the issues so well, and I relate to what you said about the use of, irrational antifungals in India or in other parts of the world, and their availability. It's not only the irrational, their availability is also a question. And you have pinpointed all the other issues related where pharmacists can step in and not only create the awareness and do the counseling, but also can take a leadership role and educate the other public health professionals about this. I'm sure we will have a lot of questions to you. Thank you very much again. Now here we go to the next presentation. And as I said, we are going to bring in the hospital pharmacy perspective and the development of antiviral and antifungal stewardship. For this presentation, we have Ms. Daria Kurupoy, who is a Vice President of European Association of Hospital Pharmacists, and she's a member of FIP AMR Commission. She's from Croatia. Hello, Daria. Welcome.
Hello.
Yeah, go ahead.
Thank you for the invitation. It's an honor to present here among distinguished speakers. So my content is about, as already Majiri told, hospital pharmacist perspective. So I will talk from the international perspective, although I represent European hospital pharmacists. Then I will talk to you about my experience due to limited resources. So we are all familiar with limited resources. Therefore, I want to share you my experiences in establishing antimicrobial stewardship. And then I will talk about challenges and possibility of hospital pharmacists. Thank you. Next slide, please. Next slide. So this is my association, but we can go further. So I will just say shortly that antimicrobial stewardship in hospital setting is dedicated to systematic measure to optimize use of antimicrobial agents. So we, as Dallas Smith already told, as drug experts, are here to promote this optimal use and help this optimal use in, as he said, in a public setting, but as well in hospitalized setting, including critically ill or immunocompromised patients. So this applies to antibacterials, antifungals, antivirals, and antiretrovirals medicines. Next slide, please. Why is antifungal and antiviral stewardship needed? As also Valeria Gigante pointed out, that there is a very high death rates from fungal infections due to high number of patients that are older and comorbid or immunocompromised. But Dallas showed us it doesn't have to be like that. They can be immunocompetent. But however, in hospital setting, we are mostly surrounded by immunocompromised patients that have longer hospitalized in intensive care unit, and they are receiving antimicrobials for a longer time. Next slide, please. So antiviral stewardship, as I said, it's really important, especially due to viral reactivation in cancer and hematology patients. And therefore, especially in the US, there are various kinds of stewardship like cytomegalovirus stewardship and antiretroviral stewardship, because medication errors can be as high as 86% due to antimicrobial prophylaxis and treatment, polypharmacy, and the use of immunosuppressants. Next slide, please. However, the studies that included clinical pharmacists, unfortunately, there are not a lot of studies, mainly they are done in US. Therefore, I am very pleased to have a lot of participants here. So I encourage you to try to be stewards in your own community and hospital and other settings that you are doing your pharmacy, even education, which is really, really important, as we heard yesterday, because antiviral stewardship and clinical pharmacies in hospital setting showed that pharmacists can help in reducing clinically significant drug-drug interactions, antiretroviral therapy related errors in hospital, and all-causes readmission rates. And also studies show that most successful interventions included clinical pharmacists together working with nurses, physicians, and of course patients, because they complete medication reconciliation on admission, review orders daily, and screen for errors at the discharge. Next slide, please. Regarding antifungal stewardship, as we focused more in our introductory speeches, which they are really important, because studies have shown that among 30 or 60% of antifungal prescriptions could be optimized or are inappropriate. So this is a really huge chance for pharmacists, not just hospital, but community as well, to optimize the antifungal therapy. For example, around 50% of patients with asymptomatic candiduria received antifungal therapy despite data suggesting the value of no treatment. Furthermore, fluconazole was routinely underdosed in 1/3 of patients with sepsis. As also retroviral therapy is expensive, but antifungal therapy is even more expensive, and it showed that it costs US $7.2 billion in 2017. In today's prices are even higher. And mortality rates, as already Valeria Gigante showed us on the case with Candida aureus, they are really, really high, and they are among the highest of all infectious diseases. Next slide, please. And how can hospital pharmacists can help? Again, by increasing optimal antifungal drug usage rate, decreasing days of antifungal therapy, and decreasing expenditure of antifungal drugs. Similar to the antiviral stewardship, hospital pharmacists being a part of a multidisciplinary team show that the pharmacist can help in de-escalating or stopping antifungal treatment. He or she can do a lot of regarding cost savings without compromising on microbiological or clinical outcomes. Next slide, please. So what is my experience? Next slide, please. So we have formed in 2017 in my hospital. I was the only clinical pharmacist. We had just one infectious disease physicians and 2 microbiologists and 1 nurse for hospital infections, which helped us a lot. We established antimicrobial stewardship team. Next slide, please. Just to tell you in short that it's really advisable to have all these steps when you approach, even in the community, to have the board approval, quality committee approval, hospital or community infection committee approval, drug and therapeutics committee approval. But the difficult part is prescribers approval. We have the most obstacles there, but we managed to sort it out. This is an example of doing this, and we developed basic indicators, process indicators, and performance indicators. For instance, basic indicators, you could have just one, like having antimicrobial stewardship program with antimicrobial stewardship team, and you do not have to do it by every day. You can choose, for instance, doing 3 days a week or once a week even, because it's really difficult to when you have resource limited setting and to establish such a theme. It's most important thing is to begin. Then to have a local guidelines to coordinate. We managed to coordinate even with the primary care systems, homes for elderly, and of course to have performance indicators so you can present your performance, how you did or did not go with your stewardship, because of course antimicrobial stewardship can also not go in a good direction regarding not having the cost savings, but you have to then show how you improved in other areas, as I will show you on the next slide, please. So we focused after discussing among our team on antibiotics reserves, as in our hospital, antifungals and antivirals medicines were under control, but antibiotics reserves were not under control. But this development you can also translate to antifungal and antiviral stewardship. So antibiotics reserves are also really expensive medicines that our patients are receiving when they are resistant to all other antibiotics in primary care. So they are really critically ill patients that are immunocompromised, and they also receiving antifungal and antiviral medicines. This is just a table to show you that the patients were similarly. We had two groups: the groups that were treated that were not having antimicrobial stewardship team before we started the intervention on 1st September of 2017, and after the intervention. So next slide, please. And then we showed how we reduced the number of patients receiving antimicrobial antibiotics reserves, from 8% to 3%. Next slide, please. So we reduced duration of hospitalization of patients from 28 to 17 days. So we saved money, but not as much, but we saved the duration of hospitalization, which is important. This is in 3 months post-intervention. We wanted to do a longer study, but unfortunately COVID came, and due to limited resources, and thanks to this investigation, I am now having 2 more clinical pharmacists that will help me to gather the evidence and to put the evidence forward regarding having hospital pharmacists in antimicrobial stewardship team. Next slide, please. So what are challenges and possibility of hospital pharmacists? Digitalization, this is still a problem in Europe, in US, and globally. As I was researching the studies, there are unfortunately studies show that digitalization is really low, even all around the world. So we do not have like automatically recording antimicrobial consumption in every hospital. This is really, really high need. So you do it manually, but we are overcoming this challenge by having a lot of enthusiasm. So in education, as I pointed out at the beginning, the prescribers were, when we received the green light from our board and others, various committees, the most difficult task was to educate our prescribers, because they were saying, I know about the infection, I learned it in the school, but we said, okay, you're a traumatologist, surgery, or a cardiologist, but we want to help you here if you have a patient with an infection. And therefore, after seeing that we are here to help, not to take their job, they really, really appreciate our help. And now we are really overwhelmed with work, because they're asking us even for some infection that could that Dallas was talking about, that could be even settled in public setting. And of course, motivation, we are still motivated, but it's really difficult sometimes because we have limited human resources and finances. And next slide, please. But possibilities, it's really nice to have this multi-interdisciplinary collaboration to do the timely intervention. So we can, when patient arrives at a hospital, we can do our intervention. And if we are not at the hospital, sorry for the telephone. If we're not at the hospital, we develop algorithms for preemptive treatment. So when we arrive, for instance, the next day at the hospital, we can see the patient and re-evaluate antimicrobial therapy. And we have the possibility of telemedicine and telepharmacy. So if you have for hospital, even pharmacists, I'm working with community pharmacists that I'm doing telemedicine or telepharmacy, trying just to help them with choosing which antimicrobial therapies best for their patients. So they're really good. We should see this not as a challenge, these limited resources, but we should see this as an opportunity. And next slide, please. So I can say for sure that there is a time for antiviral and antifungal stewardship, but unfortunately, it's still not really well raised awareness as it should be. So I really much thank FIP for doing these seminars. It's really important to raise awareness, because hospital pharmacists, but also community pharmacists, show that this stewardship reduce medication errors and improve patient outcomes. And thank you very much.
Thank you, Daria. And my congratulations to you for setting up such a successful antiviral and antifungal stewardship program and overcoming many of the obstacles. Special congratulations and appreciations for the way you handled the interaction with your prescribers. I think that is very important. And as you said rightly, we have this is the area where there is much less research and less work done. And I think it's less talked about. And so, so this is the importance of today's webinar. We are talking about it. And thank you very much for your contribution. And
thank you for the invitation.
Sharing your experience and the challenges. Thank you. And here we have Ms. Anna Kanina, and she's the Antifungal Stewardship Project Officer from the National Center for Infections in Cancer, Peter MacCallum Cancer Center in Australia. She's going to talk about development of a deep dive antifungal prescribing quality assessment tool. Thank you very much Anna for joining. I'm sure this is quite late for you in Australia, but thanks a lot, and I welcome you.
Thank you so much. Thank you for having me to talk today. Could we have the next slide, please? And the next slide as well. So just a bit of an overview of what I'm going to be talking about today. So I will touch briefly on what antifungal stewardship is and why it's important, but this has really been talked about really well by Valeria and by Daria as well earlier today. We'll talk about what guidelines exist for implementing antifungal stewardship, and then what we've done with my team to develop an evidence-based tool to assess the quality of antifungal prescribing. And we'll also just give you a bit of an overview of what this tool is, which is called the Antifungal National Antimicrobial Prescribing Survey, or the AFNAPS. So I guess the goals of antifungal stewardship really do align with those of antimicrobial stewardship. We want to optimize the use of antifungals. We want to improve the outcomes for our patients, reduce adverse sequelae, ensure that therapy is cost effective, and we want to conserve the very few antifungals that we have today. So this is really the same as it is for antimicrobial stewardship, but I guess there are some additional complexities and difficulties for managing antifungals compared to antimicrobials, and that is that these infections can be quite complex, and it does require expert knowledge in terms of understanding patient risk for infection, when prophylaxis is needed, in terms of diagnosis, understanding the diagnostics and interpreting them. And also I think really key that Daria touched on is having a good relationship with the prescribers so that you can actually influence them and try to improve their prescribing. And when it comes to antifungals, that might be even more complicated because you're often dealing with intensivists or hematologists and oncologists that are really specialized in their area and will have come across and managed fungal infections quite commonly. So to be able to come into their space and say, let me help you to do this better and to improve your prescribing can be challenging. So I think that having really strong relationships is key for antifungal stewardship. Next slide. So why is antifungal stewardship important? And again, others have touched on this already, but there are high mortality rates from yeast and mold infections, particularly when those organisms are resistant to the antifungals that we have today. We are seeing increasing at-risk groups. There's more patients that are undergoing immunosuppressive therapy, patients are living longer, and so for these reasons we're seeing increasing use of antifungals as time goes on. When a patient has an infection, this does really impact on the management of their underlying disease. So if somebody is undergoing management for a hematological malignancy, they develop a fungal infection, that might then result in them needing to withhold their immunosuppressive therapy, and it can then influence their cancer therapy significantly. As Valeria talked about, we are seeing increasing resistance to antifungals, and we have really limited treatment options at the moment. There's not too many drugs on the horizon. These medications that we have today are high in cost, and not only the medications are expensive, but also the diagnostics can be quite expensive. There are limitations to use of the antifungals that we have today. These drugs can be quite toxic. There's lots of drug interactions and complexities of using them. So having, expert knowledge is important. And we know from studies that the appropriateness of antifungal prescribing can be quite low. And there's lots of different studies that have looked into this as well. Next slide. So there are some guidelines. So in 2020, the mycosis study group published core recommendations for antifungal stewardship. In Australia, we have guidelines for antifungal stewardship as well. And next slide. These look, they do mention specifically the importance of data to drive quality improvement. So they state that facilities should evaluate the quality of antifungal prescribing systematically, and use this data to drive quality improvement strategies. We also need to be sure that we're looking at patient level outcome where possible, and that there should be mechanisms in place to direct the feedback to the prescribers. So not collecting data just for the sake of collecting data, but using that information to feedback to the prescribers, to educate them, and hopefully to improve prescribing. But how can we do this? What is available to us in the hospital setting to be able to gather this data effectively? Next slide. So in Australia, we have what's called the hospital NAPS, or the National Antimicrobial Prescribing Survey, which is an electronic audit tool. It's a yearly point prevalence audit of all antimicrobials, including antifungals, and it's used really prevalently across Australia. So in, I think, 2019, for example, almost 400 hospitals participated across the country with data entered for 20,000 patients. So it is used quite extensively. But because of the point prevalence methodology and the relatively low number of antifungals that will be captured on that one day of auditing, it's not particularly suitable for a deep dive assessment of antifungal prescribing. It doesn't allow you to look at the patient's management over a period of time. It's really just what happens on one day, and it doesn't have really specific metrics that look more closely at antifungal prescribing. So we've gone about developing an antifungal specific audit, which is the antifungal NAPS. So how have we done that? So we started off by doing a literature review, really to understand what quality metrics have been used across the world, what audit tools are used, and what methodologies are being used. And when we have a look at these metrics, next slide. There are lots of different metrics that have been used around consumption of drugs. As you can see, just some of them are described here, but also quality of prescribing, not just, and yeah, so that's, you keep clicking, sorry. Yes, so also the quality of prescribing, and then also patient outcomes. So when you look at the literature, lots of different metrics are being used in different studies. There we go. So what we see, large diversity, what this means is it makes comparison really difficult. You're not able to compare your intervention to what somebody did in a hospital in a city next to you or in a different country, and it makes it really, really difficult. So what we really need is for there to be clear guidance on how to comprehensively assess the quality of antifungal prescribing, and to be able to do this in a systematic way so that we can compare what we did to what somebody else did, and we can really understand what are the most effective interventions. Next slide. So next, what we did is called a Delphi study, and a Delphi study is a way to gather consensus amongst a group of experts. But you can do this anonymously, so that what we did was we wanted to get an understanding of what were the important metrics around the quality of antifungal prescribing, consumption, and also patient outcomes, but not just the quality, but also the feasibility. Not just the importance, but also the feasibility. While something might be just started to be really, really important, it might not be something that we can do routinely in our practice, so it's not feasible. And the study found some metrics to be of high importance with high to moderate or low feasibility. These are just some of the examples of the metrics that were looked at in the study. Next slide. So 38 metrics were agreed to be important overall, and 21 of these had moderate to high feasibility. And really the importance of this study was that it helps us to provide a framework to comprehensively assess the quantity and the quality of antifungal prescribing. We know what experts internationally think we should be looking at on a regular basis. Then we went on to do a co-design of the antifungal NAPS tool. So we had a multidisciplinary steering group, and really we looked at what we had in the old hospital NAPS. We had a look at what was found in the Delphi study, compared them and looked to see what we needed to add or how we needed to change the hospital NAPS to make it appropriate for antifungals. We piloted our tool across 8 hospitals in Australia to get an understanding of did the methodology make sense? Was it usable? And we got a lot of really valuable feedback. We then went on to do a validation and reliability study. So it's one thing to produce a tool, but we actually need to make sure that that tool is valid and reliable, and that we can confidently say that this can be used in various settings. Next slide. So I guess we aim to produce a really reliable audit tool to assess the quality of prescribing. We want to make sure we reduce the variability to allow comparison between auditors and hospitals over time, so that if I do the audit today, I'm going to assess the appropriateness of prescribing in a very, very similar way to my colleague who might do it next week or next year. And so that we can say that this year our appropriateness was 60% and the following year 80%, and we've assessed them in a similar way. And in our study, we gave example case studies, and we got different people to rate the appropriateness of the prescription based on the tools provided from the antifungal NAPS. We had infectious diseases physicians, AMS pharmacists, and also specialist pharmacists working in hematology or ICU or solid organ transplant. And we have found there was quite high accuracy and high sensitivity, but lower specificity, meaning that when a prescription was appropriate, most people could say, yes, that's appropriate. But when it was inappropriate, people tended to call it appropriate anyway. And we tried to understand why that was happening. We also looked at the reliability, which was fair. What we did find was that the pharmacists had the greatest accuracy and reliability compared to infectious diseases physicians, which is not surprising because pharmacists, I guess, we tend to follow guidelines and be a little bit more strategic in the way, or a bit more specific in the way we assess things. And AMS pharmacists and specialist pharmacists had really similar rates of accuracy, which I think is encouraging, that it's not an area that can be done by AMS pharmacists as well as pharmacists that really specialize in antifungal prescribing. And this study was really useful because it helped us to understand barriers to accurate assessment, and we could implement strategies to try to optimize the use of the tool to try to improve the accuracy, the sensitivity, and the specificity. Next slide. So this is what the antifungal NAPS is today. It's an electronic audit tool that allows a flexible audit methodology. So you can do a drug-based audit. Say you might be interested in what's happening with the echinocandins in our hospital, and you just want to focus on that. You might want to do an unit-based audit. For example, you want to know what's happening in your hematology unit, or it might be indication-based. Say we've got a lot of aspergillosis and we're interested in how we're treating that at the moment. So you can focus on that. It allows you to assess each phase of antifungal prescribing. So you can start off looking at prophylaxis in high-risk groups. You can then look at and see how empiric prescribing is done, and then directed therapy once we know what the organism is. It allows for detailed patient information and understanding the patient's risk of invasive fungal infection. So we capture what their immunocompromising condition is, how their malignancy was managed, what their IFI risk is, and this helps us to really deep dive into the data once it's been collected. We've added in some quality metrics around therapeutic drug monitoring, drug-drug interactions and contraindications. We've added in important outcome metrics around the incidence of invasive fungal infection, the rate of breakthrough infections, looking at diagnostics, and of course mortality. And we also have created detailed reporting that allows a hospital to get a quick report of their results and to identify key areas for quality improvement, and also benchmarking reports to be able to compare your results to similar hospitals. And we have developed some resources that are really important to make sure that the tool is used appropriately. We have user guides, an appropriate assessment matrix, instructional videos. We have a mandatory e-learning module, and we've also provided some work case examples to help people to step through them as they go. And next slide. Yep. This is just a sample of what it looks like. As an example, there's 4 different areas looking at patient details, adverse drug reaction, antifungals, and outcomes. Next. This is our appropriateness assessment tool, which helps you to determine if a prescription is optimal, adequate, suboptimal, or inadequate. And it's quite specific in the way that we do this. And next. And this is just, sorry, it's a bit fuzzy, but that was an example of how the report looks as well. And next. So what sort of knowledge will the antifungal NAPs generate? It's really, you can look at the quality of antifungal prescribing and reasons for inappropriate prescribing, and that can help you to then develop quality improvement interventions to target identified needs. You can look at guideline compliance. You can look whether or not your prescription is compliant with the national versus your local guidelines, and to get an understanding if your local guidelines differ from those of the national guidelines. You can look at the rate of infection, breakthrough infection, and this can, if you've got high rates of infection in your hospital compared to others, it might prompt you to review your local prophylaxis strategies or infection prevention strategies. You can benchmark performance with similar facilities. Again, you can identify differences in practice, and you can understand where, why, and how antifungals are prescribed in your hospital to target your interventions. So that was, yeah, we can skip through that. So that was just the general summary of what I wanted to talk about today, and really just to highlight the importance of data to drive quality improvement.
Thank you, Anna. So that was very informative, and congratulations for all that work in antifungal stewardship and the NAPS tool. That was very educative. Thank you so much for sharing these insights and the learnings. A lot of new learnings for everyone. I request all our speakers to come on the dais and they can have their videos on. And let me tell you that there have been a lot of compliments to each one of you for your excellent presentations, and everybody says that there is wealth of new information and a lot of new learnings, as I said. So thank you to each one of you for these excellent presentations and giving us new knowledge about this area, which is much less researched. All of us agree that this is much less researched area, much less talked about area. And this is maybe the first time that we are having a webinar on this topic. During COVID, when the mucormycosis came up, I think everybody started talking much about the fungal infections, especially in this part of the world. But even though fungal infections are so common and the pharmacists come across the patients all the time at the counter, I'm sure most of the pharmacists will agree that many of the patients who come at the counter, they come for the painkillers or the acidity problem or the skin infections. And majority of the skin infections are fungal infections. And it is very challenging for them. Self-care is a big thing, but it is much challenging for the pharmacist also to handle these kind of infections because of the resistant infections. So thank you very much for your valuable insights. And now we have some questions for you. And one of the questions which I would like to take here is how long is the interval where antifungal topicals in combination with steroid and antibiotics be reused or reapplied? With my personal experience, I was advised by the dermatologist to continuously use the cream as needed, even though I clarified that AMR may occur, but which she refuted. That's what the participant is saying. And this is very relevant question, that till how long shall we continue using the antifungal topicals? And also, I mean, these are two different things, I think, using the antifungal topicals with plain antifungals and antifungal with steroid. We talked about the irrational use and outcomes. So who would like to take this? I think this is very relevant question for all the pharmacists.
Happy to jump in first, since maybe the question arose during my presentation, but unfortunately, because it is a skin infection, ringworm is, there's not a lot of data about what's most appropriate, the length of therapy. And so what we normally say is that if it isn't resolving after 2 weeks with antifungal monotherapy, they should be getting a diagnosis. They should be going back to a physician to get an actual diagnosis, because one, it may be resistant, but two, it may not actually be ringworm. It could be a non-fungal skin infection, and they need to get diagnosed appropriately. So that's what we kind of say and recommend, but there's not a lot of great guidance around it because it's a skin infection, it's a fungal infection. Fungal infections, like Valeria knows, are very neglected. But I also want to talk about combination products, corticosteroids with antifungal creams, and those should not be used in most situations. They definitely should not be used in the first line of defense.
Yeah.
You should be using monotherapy first. If a corticosteroid, especially a high potency corticosteroid like clopidogrel, needs to be used, that should be coming from a prescriber. Pharmacists right now, because there's no point of care test, probably should not be recommending to give a high potency corticosteroid in combination with antifungal, probably at all, because they need a diagnosis. Because what happens, when we think about why these combination products are leading to emergence, we have a skin infection, we're giving a steroid, which kind of doesn't allow our immune system to really take care of the infection. And while we are given antifungal, it's probably most of the times they're fungistatic, so they're not actually killing the fungus. And so we need our immune system to help us out a little bit. And if we're giving a steroid, it's not going to get the job done in some instances.
Yes, very right. Very rightly said. Thank you very much. Any other views, Dr. Valeria?
No, thank you.
No, okay. So give the topical antifungal with plain antifungal in it, and then the patient should try that, but not the one with the steroid. And that would require physician's diagnosis, the prescription. And as you rightly said, that we don't have any point of care testing yet. In fact, I remember in your presentation, you said that so many of the skin infections, the fungal and the non-fungal, look alike. And I think this is one, so it is very difficult even for the pharmacist to judge whether it is a fungal infection. Is there any research going on for developing any point of care testing for the fungal infections? Anyone can take this question. I don't know whether is there in this direction, is there any research on? Or maybe now we realize the need for it.
Yeah, and so there are quite a lot of research around many different fungal diseases that we're trying to develop point of care tests. And so Valeria probably knows, but like for Cryptococcus, we have a great LFA or lateral flow assay that it's really great and it's deployed globally. There's a histoplasmosis LFA that looks really great and promising in many parts of the world. Unfortunately, for fungal skin diseases, it's much harder because we can't really target an antigen. We really can't target blood. And so we have to find something that you can figure out, like, do we have patients take a skin scraping? So I think it's a little harder with skin. But for invasive fungal infections, I'm probably forgetting some. There are some really great work. And I'll turn it to Valeria, who has more information.
And actually, thank you, Dallas. Yes, I can anticipate that WHO is looking into give available diagnostics already on the market and potentially coming up on the market. So we intend to embrace this landscape pipeline review on diagnostics for fungal infection in the upcoming years. And hopefully we will be able to understand what are the gaps, what are the needs, how this diagnostics could be scale up in low and middle income countries, where can they work in absence of constant power supply? Can they provide a rapid answer and an answer that is easily interpretable by healthcare providers with basic trainings? Can they be used outside tertiary healthcare hospitals? And also the most important question is that, are they affordable and they're like available and accessible to everyone globally? Because we always talk about therapies, but also diagnostics are crucial to guides therapy. So if we have potentially new effective, non-toxic antifungal therapies as we desire for invasive systemic infection, are we able also to guide our prescription with the appropriate and matching diagnostics? This is really an important point.
Yes, very rightly said. So diagnostics is very important to guide the right treatment. Thank you, Dr. Valerian, for telling us what's going on in this direction. There is one more question. Can oral thrush be treated by over-the-counter antifungals? especially if the patient has weakened immunity, is immunocompromised. Can such patient be treated by the pharmacist with over-the-counter medicines, or should the patient be referred to the physicians? Yes, Dr. Dallas?
Yeah, I'm happy to take a stab. And I really think it depends on like a specific situation. If patient's immunocompromised and has thrush, it may be indicating a larger problem. And so I don't know if I would answer either way, but I do want to mention something related to thrush. So thrush is normally caused by Candida species or candidiasis.
Yeah.
And although we didn't talk about it during this presentation, we are seeing resistance with superficial candidiasis, so thrush, vaginal candidiasis. And so while the work and we don't know a lot about the resistance, we do need to pay attention to it. And even in thrush, even in vaginal candidiasis, we should still be good stewards of over-the-counter antifungals. And so we're still looking into this. It's a little harder to get resistance information on it, but it's also another big problem that may be emerging in many parts of the world.
True. Yes. There's one more question I can quickly take. Is it possible to do integrated disease surveillance reports for regional level to assist on stewardship? I think this is a very important question again. Anna or Daria, do you want to take that? Is it possible to do integrated disease surveillance report for regional level to assist on stewardship?
So I think in
Yes,
terms
Anna.
of surveillance, in terms of surveillance of actual disease, I think it's quite complicated. So to understand what infections are occurring where is really, really complicated, because fungal infection isn't always diagnosed microbiologically. It's often a clinical diagnosis. You need to have histopathology reports. You need to have CT scans, PET scans, also just clinical knowledge. So you can't go to the lab and say, tell me everyone that's had an aspergillus infection or mucormycosis that we've had, because you're not going to get every patient that way. So I think that that's not a simple thing to do. Our team are trying to develop some automated processes for surveillance of fungal infection in the hospital setting, using natural language processing and AI to try and simplify the task, because I think manually when this is done, it's a really complicated and time-consuming thing that's often done in more of a research setting. So we're trying to automate that process to really be able to provide that data in a timely manner, like you say, to help with stewardship activities.
Right.
That's my perspective.
Yeah, thank you. Daria, do you want to add anything?
She responded really concisely. I have nothing to add.
Yeah, well done. Thank you so much. So here we come to the end of our webinar, and I would just like to wrap up by saying that this is, as everybody has said, every of our speaker has said, this is kind of a neglected area, or I would say this is something like the fungal infections have been taken very casually or lightly by many of us, and they are so fatal in the immunocompromised patients. Not only that is the concern, but also for the people who get just the ringworm infection, and that becomes a resistant ringworm infection because of maybe self-medication, wrong self-medication, or many other reasons. And the pharmacist, being the first port of call health professional, has a huge role to play. And I think we have a lot of work to do in this space, right from the diagnostics to the treatment to the public health interventions that our speakers have talked about. And this will be an area, this will be the field where we will be working together. And also now we'll be talking much about the stewardship in the area of antifungals and antivirals. And again, there are many challenges, but of course, we have to make a beginning, as rightly our speakers have said, and we will be working in this direction. I'm very thankful to all our speakers for their excellent presentations, and also to the audience for being very active, for being very appreciative, and for asking the right questions. Thank you very much to everyone who has joined this webinar from across the globe. Thank you so much. Next slide, please. And before I end this webinar, I would like to remind you that we will continue with our digital events at FIP. And also, just to tell you that we finished the FIP Congress, the 81st FIP Congress at Brisbane recently in September. And now the next Congress, that is 82nd FIP World Congress of Pharmacy and Pharmaceutical Sciences, is coming up in Cape Town, South Africa in first week of September, 1st to 4th September in 2024, with the theme Innovating for the Future of Healthcare. So please start making the plans from right now for attending this Congress at Cape Town. And thank you very much again. And please join us for the next FIP digital events. And thank you all for your attention. Thank you very much. Good evening to everyone. Thank you. Thank you to all the
Thank you.
speakers.
Bye.
Thank you so
Bye.
much. Yeah. Thank you.
Thank you.